Hi, I'm Dr. Gordon Sands. I'm a senior research physicist at Leo Cancer Care and a HCPC registered clinical scientist. My own background is I've worked in radiotherapy as a clinical physicist for 8-10 years, and I'm now looking at research in the upright radiotherapy space under Dr. Underwood's UKRI grants. This particular paper is one I found very, very interesting. One of these ones that I really wanted to try and tackle. When we think about upright radiotherapy, one of the biggest shifts in paradigm is going to be breast. The way the breast tissue falls during supine treatment is going to fall very, very differently when we're doing upright radiotherapy. And there's a lot of unanswered questions in relation to that, which is why I want to tackle with this paper. Gravity will obviously impact breast tissue in a way that you're not going to see to the same extent with things like prostate or head and neck, where you will have obviously subtle anatomical changes, but ultimately how we treat the paradigm in terms of our treatment planning isn't actually shifting that much other than bringing the patient into that kind of more comfortable position. But with breasts, we really see how the anatomy is going to impact it. We can see that it falls in a completely different way. You know, in particular, when you think about the breast tissue and how we currently plan, we often still do something like an anterior oblique beam angled with a half beam block. But when the tissue is sitting so differently, we really need to think about new ways of addressing treatment planning, new ways of addressing comfort, new ways of addressing immobilization. In this study, this was what we were trying to tackle, is like, how do we treat in this position? What does it mean for the patient? What it means for toxicities of different organs? What it means for treatment planning? We're really, really lucky for this paper as well, because we had such a massive cohort of different authors who all brought different skill sets to the table. We were very, very lucky that we had Dr. Elizabeth Chabner highly involved with this study as well. So she came and took part and helped us fit her radiotherapy bra on these healthy participants. And just to kind of give some context of the setup of this study, we got a lot of healthy volunteers who agreed to take part, and we positioned them in one of our research upright positioning system. And we're able to look at a lot of different metrics when it comes to the challenges associated with breast radiotherapy treatment. How reproducible was the position? Did we have issues with contralateral breast clipping? What type of beam angles could we even just treat without hitting the arm, without hitting the other breast? How large were the fields? You know, we know that the length of field has an impact on the amount of lung tissue that's treated. So how was the length of fields impacted by these various upright positions? And we looked at a few different things when doing this. You know, we looked at arms up, arms by side, arms back, and we're able to kind of assess how these different factors were impacted based on these different positions. One of the interesting challenges when it comes to these types of studies is the absence of CT or MRI data. You know, CT data we know has ionizing radiation. It's not always ideal for healthy participants. And while MRI data is absolutely fantastic, having this kind of pre-work done on kind of what's the best position and how it works means that when you do have access to your upright MRI scanner, you can really just go ahead quickly with it. So to counteract that challenge, I looked at using 3D models instead. You know, we had these little cameras, we walked around the participants and it built a full 3D model of them. So once we had these models, then we could actually just look at the breast tissue and like literally just look at the external contour of the body and use that to assess where you would treat if you were applying this clinically. Now, obviously there's some disadvantages to this technique. You know, obviously when you're looking at the external breast tissue, it's not necessarily always fully representative of the internal anatomy. On top of that as well, you obviously don't have organ at risk data. But for this kind of initial study where you're just starting to look at things like contralateral breast clipping, arm clipping, how high you can get the arms, things like that, having these 3D models of the external contour of the patient can get us some really, really interesting information. And, you know, in this case as well, we're even able to kind of convert that 3D model into a sort of a DICOM file. Obviously, there's no internal information, but you got the outline, and bring it into the treatment planning system and actually look at how you would actually even apply a plan here. You know, in this case, what I did was I looked at the external breast tissue. I used that to basically kind of come up with an outline of where I would probably want to treat in a clinical scenario and use that as an estimation for like different beam angles and things like that. a lot more work to be done in this area, but having this initial pilot study where we can use the surface scanning has been absolutely fantastic. And we've been using that information to look at our next study, which is using MRI data. We've got healthy participants now going into an upright MRI scanner with the University of Nottingham, and we can really start looking at the position and how we want to position them based on this initial surface scanning data. And then, of course, one of the things we looked at as well is comfort. How comfortable did these participants find this? When we think of lying down versus the upright position, this is kind of one of the bits of feedback we do get when we have these healthy volunteer studies. They do find it comfortable. They do find that it is better for them. One of the things that was really, really interesting is when we think of current supine techniques, we really usually have them a bit like this. Things like the breast board or the wing board are very, very common practice now in current radiotherapy, which involves this kind of very stretching. With this study, we actually looked at a completely new novel technique for positioning the arms, which was designed by one of our fantastic engineers. And then we're able to look at how that works in sort of treatment. We're able to start looking at, okay, if the arm's up here, what's that mean in terms of beam axis? What's the likelihood of us clipping the other breast? For any people working in radiotherapy, contralateral breast clipping is something we really, really want to avoid. And we're able to really look at these things and look at the amount of, flexibility we have in terms of treatment planning when using this type of immobilization. The other thing as well is quite interesting, which isn't really currently done, is we're able to look at arms back and arms by side for treatment. And while these definitely reduced the options for treatment planning, for some of the participants, this was a viable option. We were able to kind of successfully treat the whole breast based on this kind of surface scanning technique where we use the contour of the breast to establish the target, think old school breast planning. And for some participants, we could treat in an arms by side or arms back position, even for photons. And where I find that really interesting is you think about what a lot of these breast cancer patients have gone through. They will often have surgery. They will often be stretching the scars, and it can be quite painful. So when you think about arms back, that might actually also be a new viable way of treating patients where they might struggle with this. One of the things we kind of touched on a little bit as well was this idea of one arm down and one arm up. We didn't really look that much at the photon axis for that one, but we just looked at as a concept that maybe this is something we could do. It's one of these papers where we've answered a lot of questions, but we've opened up a lot more. And I'm quite excited for those next steps. The main kind of takeaway points from this paper were that with the bra on, we can really reduce the skin fold size. In general, reproducibility was quite successful in the upright position. It's going to be one of these things where the data really is going to be very, very interesting as we start going on to treat. It's one of the questions that people have when they ask me about upright radiotherapy. When people are lying down, we know that's a reproducible position, but what about when they are upright? And we're able to capture some of that data and look at things like, this is how much we expect to move. This is how much time we expect a radiation therapist or radiographer to take setting up the patient compared to just standard current techniques. We had some really good results in this regard, that we could actually see that if we took people out of the sitting position and put them straight back in, that in general, they got very, very close to what will be the reproducible treatment position. That in itself is going to be quite interesting, as we say, as when we move forward. One of the things that could be quite exciting about this technology, but we're still trying to gather the data on it, is can we get more patients treated? Access to radiotherapy is a problem right now worldwide. And when we think about our system, that if we can actually reduce the amount of time patients spend being set up by the radiographer, radiation therapist, and reduce the amount of time they need to spend in the department, it also means that we can treat more patients with less resources. And, when we look at factors that are affecting middle income countries right now, how we get more patients into a radiotherapy department is such an important factor. And if we can show that we can have a quicker unaided reproducibility, we are one step closer to reducing those time slots spent in the department. I think this is a really good first step in terms of looking at upright breast radiotherapy treatments, but it also opens the door to a lot more questions. And I think, physicists, I'm excited about those questions. I think first thing we need to do next is look at getting imaging data, looking at the internal anatomy. How would these kind of beam axis questions and answers we got from this paper, how would that affect things like the heart dose, the lung dose? Ultimately, it's about when we're actually treating our first breast radiotherapy patients, what is going to be the most comfortable way to set them up? How are we going to set them up? What immobilization we're going to use? And being able to start answering those questions really means that we can really start driving forward and look at how the first few patients will experience upright radiotherapy compared to the supine techniques used today. It's the questions we have to answer are never going to end, but it's just, to me, the excitement around that is just really good. And hopefully, what it means for patients will ultimately be really, really beneficial.